All right, welcome to Valley View University. My name is Noel Armstrong. A few things they asked me to go over before I begin this lecture. Thank you for joining us today. You can submit questions if you have questions through the Q&A chat at the bottom of your screen. Some of those questions are going to be answered during the actual presentation. We have people here who can answer questions. If there's something that they want me to answer, or you want me to answer, please feel free to wait until the end when we can go over those things. One thing that's kind of important too to mention is don't send us any personal health information. Okay, this is not a secure way to share your health information. So make sure that your questions are suitably vague, that you can't be identified. And with that, let's get started. Today, I'm going to be talking about the perils of bipedalism. So really what this lecture is just a few of the common foot complaints and an update on some of the treatments and some of the information we have about them. I did want to organize it under something and give it kind of an epic title. So I called it the Perils of Bipedalism. Because one thing that I enjoy doing as I'm going through these topics is kind of looking at the big picture, looking at who we are and how we got to where we are. Plays into the problems that we face, the challenges that we face, and then what can keep us in the best shape and keep us going the best. So if you'll bear with me, I want to go through a little bit of the big picture of bipedalism. Now, bipedalism, as you know, I'm sure, is walking upright on 2 feet. See if I can get that to go. And it is crucial to who we are, so much so that all the way back in the 4th century, Plato, one of the greatest minds in history, chose to identify us, to describe us as the featherless bipeds, I guess to distinguish us from birds. And he was celebrated for this definition. The Greeks loved these kind of the most parsimonious definition you could give for anything. So people thought, oh, that's a great description of who humans are. Well, Diogenes the Cynic heard that description, and by cynic, what we mean in that day would have been like a troll. So he plucked a chicken, brought the chicken into Plato's academy, and threw it on the ground and said, here is Plato's chicken. And so Plato had to revise his definition and say that humans are featherless bipeds with flat, wide nails. And so not Plato's greatest moment, but he was onto something that's very important, critical to who we are, that we walk upright on 2 legs. So much so that a lot of the other things, if you look at kind of the elevator pitch, the short list of things that define or at least separate us from other animals or creatures, large brains, culture, that we have large cultural groups, that we can share cultural information. We have a complicated language to communicate with. Opposable thumbs, very dexterous hands, more so than any other creature in the animal kingdom. Many of those things they think came after we started walking upright on 2 legs and were actually made possible by the fact that we do walk upright on 2 legs. So I want to go through that a little bit. The development of bipedal gait is a concern of paleoanthropologists. They really want to know when this all started. So far, from the best evidence that we have, almost 7 million years ago, it might have started. This skull that you see right here is from a creature called Sahelanthropus chadensis. 7 million years old, found in Chad in Africa. And they believe that this 7 million year old skull belonged to an animal that walked upright on 2 legs. Now, this is the only fossil they have from it. So how do they know that? Well, because if you look at the bottom of the skull here, the foramen magnum, the place where the spinal cord exits the skull, sits more directly under the center of mass of the skull. And so in animals that walk on 4 legs, the foramen magnum will take its origin in the back of the skull. Because this is right under the center of mass, they believe that this is a creature that held its head upright and most likely walked on 2 legs. This quote, I think, is important. In terms of human evolution, let's go back here. In terms of human evolution, excuse me, the slide is not allowing me. In the broader context, it's now generally considered that the development of obligate bipedal locomotion is one of the most significant adaptations to occur. It preceded our having big brains. It preceded us being able to use our hands well. But as I mentioned in the title of the talk, it also came with its perils, and we're going to talk about those. It'll become relevant, I hope, soon. But I love this kind of stuff, so bear with me as I go through a little bit. Whether or not that 7 million-year-old skull belonged to a creature that walked upright on two legs, we do know that at least by 3.7 million years ago, there was bipedal gait. You've probably heard of Lucy. That is a species known as Australopithecus afarensis. Lucy, we know, walked upright on two legs. This is one of the most haunting, I guess, kind of the most stunning finds in the history of anthropology. A group in Tanzania, in an area known as the Olduvai Gorge, is looking at a few fossilized footprints from rhinoceros, things like that, and they're screwing around a little bit, horsing around. One of the scientists throws elephant dung at the other. He ducks, tries to miss it, falls on the ground, looks at the ground, and is staring straight at this set of footprints. And he realizes that these look like human footprints. Well, the footprints are excavated, they're studied, they're found to be 3.7 million years old. And they believe that that belonged to that species, Australopithecus afarensis. If you look at these prints, and they've been studied extensively, you compare a modern human foot in that print on the right to these prints at the Laetoli site, it's called, in Tanzania. You can see that that gait, the pressure pattern under that foot, very closely mimics a modern human footprint. Another one they have found in Kenya, about 500 miles away from where they found those Australopithecus prints. They found prints from Homo erectus. These prints are 1.5 million years old. These prints are almost exactly the same in their pressure pattern and distribution as a modern human footprint. And even though they vary a little bit in the pressure pattern on the foot and how high the arch is, scientists can tell that they essentially walked heel toe, propelled off the big toe in the same way that modern humans did. The reasons for this are a big question mark right now. Nobody knows exactly what all the forces were that contributed to us developing bipedal gait. And by us, I mean our hominin ancestors. Why did they start walking on two legs? You've probably heard the idea that during the Miocene, as the forest receded, the savanna grasslands spread around. And so in a grassland, if you walk upright, you can see over the top of the grass. That makes it easier to see your prey or your predators, and so it's safer. But a lot of people don't buy into that because, of course, if you can see them, they can also see you. So there are other thoughts behind why that bipedalism, why walking on 2 feet developed. One thing we know for sure, though, is that we can say with some certainty is it didn't develop so that we could become faster sprinters than the things that we're chasing or might be chasing us. And as evidence of this, I'm just going to show you, this is a graphic representation of Usain Bolt, the fastest human, as far as we know, the fastest human ever. And he's running against a greyhound in this race. The greyhound would be exactly the same speed as the African wild dog. So one potential predator of early humans would have been the African wild dogs. And you will see that there's a huge mismatch in how fast we are at sprinting versus other animals with this. So here you see it crosses the finish line 4 seconds faster than Usain Bolt. To give you an idea of what it would feel like trying to run down a wild dog. And then let's say we had a head start and tried to outrun it to escape. You get an idea how difficult that would be. So it's pretty sobering to realize too that Usain Bolt can run 25. I think he's hit a speed of 27 miles per hour. Most of us, a healthy, young, relatively athletic person, might be able to hit a speed of 15 to 17 miles per hour. And so sprinting speed is not our forte. Usain Bolt would be outrun by a house cat, by a rhinoceros, by many things that you wouldn't normally assume could outrun us. So it wasn't for sprinting speed that we developed bipedal gait. So what other possibilities are there? Let's switch to the next slide here. There we go. There are some other thoughts. One of the things that bipedalism did is free up our hands. Okay. By freeing up our hands, we were able to develop dexterity, and our dexterity is unrivaled. As far as our fine motor control, we are very, very effective at fine motor control. One thing that we're also unique in the animal kingdom in is throwing. And you think about what an advantage it would be to be able to throw things, to stand a distance away from something and throw a spear or rocks at it. Just to give you an idea of how good we are at throwing, I wanted to show you this video. Essentially, a 10-year-old child can throw a ball more accurately and with greater speed than a full-grown chimpanzee. Now watch this, it's terrible. So that is showing you how an adult chimpanzee that's 1.5 times stronger than a human. You probably heard that chimpanzees are stronger than humans by 3 or 4 times. That's not true, but they are stronger than we are. They're probably 1.5 times stronger than we are pound for pound. But they can't throw. They don't have the shoulder girdle flexibility. The human shoulder girdle is a marvel. The fastest motion that we are capable of as humans is the rotation in our shoulder. It's where all of that speed goes to throw the ball. 9,000 degrees per second, as I'm sure the orthopedist could tell you. So there's an idea that it freed up our hands for dexterity and also for throwing. But one other thing that you've probably heard, a while ago, there was a book that came out called Born to Run, and it talked about how effective we are at endurance running. So even though we don't run very fast, we can run for a very long distance. And so there's a thought that persistence hunting, which is the idea, and certain Bushmen and different tribes will still use persistence hunting to this very day, where they will simply run an animal until the animal can't keep running any longer. It just collapses from sheer exhaustion, however many miles that will take. You've probably also heard that we can run farther. I think the book Born to Run claims that we can run farther than any other animal before we become exhausted. I'm just going to say now, I think I have to burst that bubble. We cannot possibly keep up with a camel or a pronghorn, pretty much no matter what the distance is. A camel and a pronghorn could run a 26-mile marathon in 45 minutes. They could stop, rest, and drink and eat for another hour and 15, 20 minutes before the human caught up to them. So really, there are other animals that can go farther than we can over the course of many days. But we're still very, very effective at long distance and persistence running. So one thought was that bipedalism, being a much more efficient gait than walking on 4 legs, 25%. So we can go 4 miles for every 3 miles that a chimpanzee of the same weight can go. We also have a higher VO2 max. We're able to use oxygen more effectively, and we're able to go much longer distances. And that would be effective in travel, in exploration, and also, as we said, in persistence hunting. So there's some thought that that's why bipedalism developed. There are other thoughts. I don't want to get into that too much. I just love this kind of stuff, so I tend to dwell on it a little bit. But the fact is that we were born not just to walk, but our anatomy was born for us to be able to run. So take, for example, our glutes. We have large glutes, some of us larger than others. Those large glutes really are not activated during normal walking. But when you get into a running gait, or you scramble, or you're climbing, then your glutes become activated. So we are born not just to walk. We have 20 miles worth of glycogen storage, so that we can use up that glycogen going very long distances. Our tendons are highly elastic. They store energy. I think I saw one study saying that our iliotibial band can store 95% more energy for rebound and just bouncing along as we're running than the closest other great ape. So we're capable of covering large distances. We're capable of maintaining a running gait or a walking gait for a long, long period of time. The other thing is that short toes, this is another interesting aside. I don't know how critical this is, but a study in the Journal of Experimental Biology, the shorter your toes are, the less mechanical work you have to do to propel yourself off of your foot. So having really long toes is a little bit of a disadvantage. If you increase your toe length 20%, you have to use twice as much energy to propel off the ball of your foot as if you had 20% shorter toes. So there are many adaptations that we have that enable us to be very effective at what we do. And kind of the point, one of the main points of this lecture is not only are we capable of doing these things, not only are we uniquely suited for covering long distances, for using our feet to move us over a long period of time and over long distances, it's important that we do it. It's important for us, for our health, for who we are, that we actually do bipedalism, not just that we have the ability to walk upright, but we need to use that. I'll get into this slide a little bit more. But nearly the key to this slide that I wanted to point out is nearly every organ system in our body is implicated in how important it is for us to exercise all the way down to the cellular level. Exercise is critical for us to maintain ourselves at our optimal level of health. And here's an example of why. This is Oliver the chimp. Oliver basically sits around all day. He may sprint a little bit here and there. Chimp can sprint at 25 miles per hour, just like Usain Bolt, but they can only do it for a very short distance. He sleeps more than a human sleeps. He pretty much doesn't eat a very high protein rich diet. He eats some monkey chow, some fruits and vegetables. And yet, if you look at Oliver, he has 10% body fat. He has the body fat of an Olympic athlete. Okay, he doesn't get hypertension as he ages, like humans naturally seem to do. His arteries do not fill with cholesterol plaques. He doesn't get heart disease in the same type of heart disease that humans get. Chimps get a thing called fibrotic heart disease, but they don't get atherosclerotic or clogged artery heart disease like humans do. And all of these things, he doesn't have to work for. Now, if a human lived his lifestyle, we would not look like that. And we would have many of the problems that Oliver doesn't have. This is because the hunter-gatherer lifestyle does seem to be a little healthier for us, covering 15 to 18,000 steps per day. Humans need far less sleep. We average about 7 hours of sleep worldwide, globally. I know you hear about 8 hours of sleep all the time, but the average seems to be much closer to 7 hours of sleep that humans will naturally just adapt to. We also have a lot of risks for being sedentary. We have a decreased sense of well-being. Depression is much more common when we're sedentary. Difficulty sleeping. We gain weight, get diabetes, cardiovascular disease, all of those things that Oliver somehow is spared from. If we don't use our ability to move, then we are much more prone to them. So movement is life. Now, this is AI. And I think I mentioned this earlier. The way you can tell it's AI is you look at the hands and the feet. AI cannot generate very accurate hands or feet. But the point of this slide, I think, is important. One of the biggest studies ever done on step count and human health recently was completed in the European Journal of Preventive Cardiology in 2023. They studied basically over 250,000 people. And they found some very surprising facts. The first thing is, if you take just 4,000 steps per day, we all have those goals of 10,000 steps per day or whatever, we've heard of them. If you take just 4,000 steps per day, you reduce your all-cause mortality dramatically. If you take just 2,400 steps per day, you reduce your risk of cardiovascular mortality. So if you're over 60, taking between 6,000 and 10,000 steps per day lowers your risk of mortality by 42%. And this is when every other variable is controlled. Okay? So any complicating factors that you may have, if you take that many steps, your risk of mortality, 42% lower. If you're below 60, the benefits are even greater, more dramatic, 49% lower risk of all-cause mortality. And there's really no upper limit to this. This is another interesting thing about this study. They watched people who walked 20,000, 25,000 steps per day, and the benefits kept accruing. Maybe not at the same dramatic level, but we don't know the upper limit at which we stop deriving benefits from being active, from using our ability to be up on our feet. So the problem, though, is that it is not, bipedalism, walking on our 2 feet, is not without its perils. It came at a cost. Let's just put it that way. It takes a long time to learn to walk. It takes on average about a year for an infant to develop the ability to walk, to start toddling around. It's also, as most of us know, you do suffer from things like low back pain, you're higher risk for hernias, our sinuses don't drain right, our pelvic girdle makes childbirth very difficult. So there are a lot of different problems that in our bodies, bipedalism seems to exacerbate or worsen. But injuries to the foot and ankle are certainly very common. And you can even look at this in the fossil records. You can see that long bone fractures, things like club feet, are fairly common. Long bone fractures, fracture of the femur, fracture of the tibia, the leg bones, they're not uncommon. And they can actually find that there were heel fractures that are millions of years old. And so we know that as people, we've been taking care of each other for a very long time. Because in a hunter-gatherer society, there is no way that you could successfully recover from a long bone fracture without the help of the people around you. The group would have to contribute to keeping a wounded member alive until it could heal. So a lot of interesting findings related to that. The other thing is a lot of our overuse injuries come from the way in which we now walk. So you notice on the left is probably the environment in which bipedalism or walking upright and getting around developed. Varied terrain. The terrain tends to be softer. There's a lot of motion in the foot as it adapts to different terrain. It uses various muscles. The foot is unshod, meaning no shoes. And so the foot is itself adapting and using its muscles, using the joints within itself, the flexibility within the ligaments and tendons to adapt to different terrains. Whereas now we spend our whole day standing on artificial, hard, flat surfaces in shoes. So there are very different types of environment that we now inhabit from those in which we developed. If you look, and because of all that, the lower extremity is very frequently injured. It's an area that takes a tremendous amount of stress. Some of the most common injuries that we face come to our foot and ankle. In fact, in most studies that I was able to check this with, the most common injury, acute injury, suffered at work, suffered by athletes, is an ankle inversion injury. Probably most of you have had an ankle injury at some point in your life, or at least you know somebody who has. But along with those acute injuries, the fractures, the falls, the twists, the ruptures of the Achilles, all those things that we are prone to, there are a lot of overuse injuries. Those are even more common. Overuse injuries are those injuries that accumulate gradually. 70% of people in America will experience foot problems of varying degrees in their lifetime. And by that, what this study meant was that they will have a foot problem severe enough that they'll have to see somebody for it, whether it's their doctor, chiropractor, podiatrist, foot and ankle orthopedist, they'll see somebody for those foot problems. And in any given year, 20% of the population has a foot problem. That doesn't always mean they have to go in to a doctor for it, but they have an identifiable foot problem, a noticeable foot problem. Very, very common. Our feet take a lot of beating. They walk around the earth several times in a lifetime. So I'm now going to switch and just talk about some of the more common things that I see. Some of these I might have covered in previous lectures, and if I have, I'm just going to update it a little bit. One of the most common things that I see, probably the second most common thing that I see, and I'll get to number one in a minute, is what's called the Morton's neuroma. This is an interesting name because this is not a true neuroma. It's what's called a pseudo-neuroma. A true neuroma would be nerve fibers, and I'll switch to this slide. And by the way, about these slides, some of them are terrible. Too many words and far too technical. This is repurposed from a lecture that was given to medical professionals. So I will try to explain everything, but don't worry about reading every word on these slides. If you look at the right where it says Morton's neuroma, you see that it's mostly fibrous bands within and around the nerve. It is fibrous tissue. So in other words, scar-like tissue around the nerve. If it were a true neuroma, then the nerve itself would be what enlarges, but instead it's the fibrous tissue around the nerve. And it comes from repetitive stress. The most common area where I see it 95% of the time is going to be between the third and fourth toes on the ball of the foot. Some of you may feel like a sock is wadded up under your foot. You may feel shooting or tingling or numbness in your toes. You may be able even to predict when this is going to happen. You may say, you know what, I'm going to walk 1 mile and it's going to start to hurt. And then I have to take off my shoes and stop walking. That is classic for Morton's neuroma. It tends to get a little worse over time. One thing that I thought was a very interesting statistic is that 33% of the population has a Morton's neuroma that you can identify on exam. That doesn't mean they're symptomatic. I'd say many, many neuromas, people don't even know that they're there. We're looking at something else and we say, oh, by the way, did you know you had a neuroma? But when they become symptomatic, they can become uniquely very painful. So that's the Morton's neuroma. More common in a foot like this with a wide forefoot. So the wider the foot, the more the shoe tends to squeeze the foot together. As it squeezes the foot together, you see those bones on each side of the neuroma become compressed and the nerve becomes compressed. So not only is the ground pushing on it from below, the bones are pushing on it from the side if you pack that foot into a tight shoe. The one thing that I want to get across to you today is probably the most important would be almost everything that I'm going to be talking about today has one common factor, one common denominator that raises the risk factor dramatically, and that is what we call equinus, what you would call tight calf muscles. So tight calf muscles increase the pressure on the ball of your foot, and they increase your risk for neuromas. So about 3 to 5 years ago, we started telling people to stretch. When you have a Morton's neuroma, you have pain on the ball of the foot, you have to do your calf stretching. Stretch your hamstrings too, but you have to stretch your calves in order to decrease the stresses on the ball of your foot. And that seems to help almost every foot problem. I'm not exaggerating when I say that. Some of the other things that a neuroma could be, we're going to talk about. I don't want to get into that too much. There are theories about why the neuroma forms. Some of this gets a little technical. Just to summarize it, repetitive stress on the ball of the foot seems to cause injury to the nerve, and the nerve responds to that injury by trying to build up thickened fibrous tissue around its sheath. And instead of protecting the nerve, instead of making that nerve less vulnerable to injury, like the fibrous tissue would be protected, it actually makes it larger and makes it much more prone to injury. There is another thought that some of it has to do with cut off blood supply to the nerve, little swollen sacs of fluid between the metatarsals. But most of the time we consider it pressure and compression, repetitive stress injury. If you have questions about neuroma, please feel free to submit them. I will move on from that at this point. I want to talk about another thing that most people are not familiar with, and that's what's called the plantar plate. A lot of people have heard of Morton's neuromas. Many people have heard of hammer toes. That's what these are, by the way. Those toes that overlap the big toe and move to the side, they're called hammer toes. But the injury that allows hammer toes to form is an injury to the strong fibrocartilaginous structure on the ball of the foot that stabilizes and holds that joint in place. And that fibrocartilage, that strong structure, is called the plantar plate. So the plantar plate, if you look, this is a tendon. That plantar fascia connection to it is ligamentous. And then there's a bone called the proximal phalanx. And then you see the plantar plate. It is very dense. It's very tough. It almost looks like bone. It's so strong. And that's what keeps your toes from drifting out of position. Now, again, because we walk on our feet and because we have very, very rigid, very effective, efficient levers to push off with, that takes a tremendous amount of stress as we push off the ball of our foot. We drive a lot of force through that. And year after year, step after step, that holds up. But occasionally, in some feet more than others, people with tight calf muscles, people with not much arch on the ball of their foot, it will break down. And when it breaks down, we call it a plantar plate tear, plantar plate rupture. It leads to a lot of pain. The toes become unstable. This is different from neuroma pain, but it's really hard to tell it apart sometimes. The neuroma pain is going to feel usually more sharp. It's going to come on after you've been on your foot for a while. Neuroma is usually relieved by taking your shoe off, rubbing the area, and letting it all calm down. Whereas plantar plate pain is usually much more predictable. Every time you push on it, it feels pretty sore. You can't get that pain to go away just by taking your shoe off and letting your foot kind of breathe for a while. The pain stays there. And if it goes on long enough, you're going to see your toes starting to drift into a hammer toe. Luckily, a lot of the time, we're able to catch people who have this problem, whose plantar plate has been injured, before their toes become deformed. Once your toes are deformed, there's no way to get them back into position. Once you have a hammer toe, there's no way to get that hammer toe to go back into position without doing either an office-based procedure or an OR-based surgery. So the hope is that you could catch it when you first have that pain on the ball of your foot. And if you can catch it, then you can lift pressure off of the site by doing a pressure relief pad, which I think I show right here. These little pads called metatarsal cookies treat neuromas and plantar plate injuries. You can also, there are ways that you can tape and stabilize the toe until the plantar plate heals. There are activities that you can avoid. And again, calf stretching is very important for the long-term success of not developing hammer toes, flexibility of the posterior muscles in your leg, your calf, so basically your gastrocnemius and your soleus. You should be stretching regularly. I think that's enough about plantar plate. If you have any questions about that, let me know. Sometimes you'll see the term metatarsalgia. That just means pain in the joints on the ball of your foot. Sometimes that's from a plantar plate tear, but not always. Sometimes you just have some bruising on the ball of your foot, feels like a stone bruise. And so anyway, that plantar plate tear is just something to be aware of because you don't want it to be ignored. You don't want it to become hammer toes. Once your toes are deformed, they can't be put back without surgery. This is an interesting finding you'll often see in people with a plantar plate tear. If you look at the arc of the foot, everybody knows that your foot has an arch on the side. It's also supposed to have an arch across the ball of the foot, where the second and third toe, where they weight bear, is a little higher than the first and fifth toe. So the tripod of the foot would be the heel, the first metatarsal head, and the fifth metatarsal head. Well, you see on this foot, that arch is inverted. Where there should be a concavity, there's a convexity on the bottom of the foot. And so this person is walking with far too much force on the ball of their foot. As it becomes irritated, that swells even more. So you develop even a more deformed arch on the ball of your foot. And that, of course, just worsens the deformity. There are ways to test for this that we do in the office. I don't want to get into all of these kinds of things, but realize that if you're starting to feel pain on the ball of the foot, it may be plantar plate tear. It might be a neuroma. All of these things are overuse injuries, very, very common. This is just showing the tape that we like to apply to protect the plantar plate. Again, if you have questions about that, let me know. You can do a tendon transfer and repair it, but let's not get into that. This, of course, is by far the most common thing that we see in any foot and ankle clinic, my clinic notwithstanding, plantar fasciitis. An interesting finding in humans. If you look at gorillas, orangutans, chimpanzees, when they're born, their heel is fairly stout. As they develop into maturity, their heel becomes thinner and weaker, what they call more gracile. The human heel, though, when we're born, it's a certain level of sturdiness. And as we age and mature, it becomes much, much stronger, much more stout. And we're the only members of what the scientists would call the hominid family, where our heel bone gets stronger and stouter as we age instead of becoming thinner and weaker. And that all has to do with the fact that the way that we walk and the amount of time that we spend on our 2 feet puts a tremendous amount of force through our heel. Heel bone's a very sturdy structure. It can stand up to it, but it does take a beating. And another structure that takes a tremendous beating is that strap of tissue, the plantar fascia, that takes origin from the heel. See if I have a picture of it. Yeah, so right here, you can see a side view of the foot. You see the Achilles tendon coming down and attaching into the heel bone. And then on the bottom of the heel, you see the plantar fascia, and you see a white area of bone where that plantar fascia and the heel bone around it are inflamed. That area takes a tremendous amount of stress. The plantar fascia is designed to take that kind of stress, but there is a limit to it. It can get overloaded. There was a big study that came out. You know, when we talk to people about why do we have plantar fasciitis, what caused it, it's not always easy to give a definitive answer, because most of the people who come in with fasciitis say, I didn't do anything. I didn't change what I'm doing. I have no new shoes. I have no new job. I didn't start a new exercise program. And now my heel is killing me. And so those people, we don't always know exactly what starts it, but we do know from this study in the Journal of Bone and Joint Surgery, risk factors for plantar fasciitis, we do know that there are a few independent risk factors. Anybody can get plantar fasciitis, but you're more likely to get plantar fasciitis if you have reduced ankle dorsiflexion. That again is tight calf muscle. So reduced ability to dorsiflex or lift your foot up is most often because you have what we call an equinus. You have tightness of the calf muscles. That, as you see in the highlighted part of that text near the bottom, reduced ankle dorsiflexion appears to be the most important risk factor. That also tends to be the most important treatment in plantar fasciitis. So I do want to give you just a little bit of an update about plantar fasciitis. I don't know how many of you have had plantar fasciitis. I know that you're looking for practical solutions and advice on this, and I'm happy to offer that. I think the key in study after study, the most effective treatment for fasciitis, just statistically, is that you stretch the posterior, the back of your leg. You stretch your gastrocnemius, stretch your soleus. You do it intensively. You do it frequently. It seems like you're always stretching when you have fasciitis. And if you do that, your odds of recovering from it are actually very high. It's very rare that it stays and that it persists past a good, effective treatment program. Of course, you want to modify activities. You want to wear comfortable shoes. But this is one thing I do want to point out because it has to do with a lot of different things, not just foot and ankle, but any tendon in the body. Scientists have found out that there are different types of stem cells in our tissue. Now, as you know, stem cells are immature cells that then can mature into different types of cells. Well, in the plantar fascia, and as it turns out in some tendons, there are stem cells that can differentiate in a number of different ways. Those stem cells normally, under normal stress loads, turn into a thing called fibroblasts. And they knit the strong collagen, that tough tissue that makes your plantar fascia strong, that repairs any tears, that keeps it well organized and functioning normally. So with mild, moderate stress, just normal activity level, your plantar fascia repairs itself. And the same could be said for your Achilles, for any number of tendons and areas in your body. When the level of stress gets too high, and they actually quantified this, they found that if the plantar fascia stretches more than 4% of its length, so if the stresses get too high through tight calf muscles, through obesity, through some of those other factors that you saw there, if the stress gets too high, then those stem cells, those immature cells, don't turn into the kind of cells we want them to turn into. They don't turn into fibroblasts. They actually turn into one of 3 abnormal types of cells. One of them is the type of cell that makes fat. Another is the type of cell that makes cartilage. And finally, it can turn into the type of cell that makes bone. So people will often develop bone spurs when they have a case of chronic fasciitis. We have known for a long time the spurs are not the cause of the problem. The spurs are a result of the problem. Problem is too high levels of stress, putting too much tension on the plantar fascia. The cells that should be knitting the tissue together, repairing it, keeping it healthy, either turn into fatty cells that make the fatty degeneration that we sometimes see when we see a degenerative tendon or a degenerative plantar fascia, or they turn into cartilage cells. And cartilage is not the right type of tissue for your plantar fascia. It's too dense, it has no flexibility, it doesn't absorb force in the right way, it has the wrong elastic modulus, is what we would say. So it is not a component of healthy plantar fascia. And then finally, you can also get bone spurs, calcium deposits. You can see these in the Achilles insertion of the heel and in the plantar fascia. And that all has to do with the fact that these stem cells turn into the wrong kind of cell if they're under too much stress. So I thought that was fairly interesting. And one more thing that I want to point out to you before I close. That is, for a long time, we haven't known what causes some of the pain from fasciitis. Initially, we thought it was inflamed. Well, then we thought, well, listen, we can't find any inflammatory cells when we go in surgically and take a biopsy of plantar fasciitis. It's not red, it's not swollen, it's not hot to the touch. If you've had plantar fasciitis, you know it just looks like the other heel, pretty much. It's cold to the touch, it's not swollen, it's not tense, and yet it feels very painful. And a cortisone shot works. Well, if a cortisone shot works, why could we say it's not inflamed? Well, this study from the Scandinavian Journal of Pain from 2022, I found very informative because they found that tendon pain, fascia pain, they're both very, very similar, come from what's called neuroinflammation. And I don't want to get too into it. It's a different type of inflammation. It has different chemical signals, different cells involved, and in normal healthy tendon and normal healthy core of your plantar fascia, there just aren't nerves. Okay, but when there is repetitive stress injury, so healthy pain-free tendons, they don't have any nerve fibers. Okay, but in a chronically painful injured plantar fascia or an injured tendon, you do have nerves that grow into that structure. So you'll have nerves that grow into the plantar fascia, nerves that grow into the tendon. And then what happens is those nerves start to release signals. Those signals are pain signals. What we call substance P is one of the big pain signals. Substance P, and I think P stands for pain actually. Substance P actually causes what's called mast cells. If you know anything about allergies, then you've probably heard of mast cells. Then the mast cells will degranulate and they release painful and damaging chemicals into the tendon and into the plantar fascia. So normally there shouldn't be nerves in your plantar fascia. There shouldn't be nerves within the tendon. Under conditions of injury, overload, and stress, nerves grow into the tendon. They grow into the plantar fascia, and they do release inflammatory chemicals. They're just a different kind of inflammation. The good news about that is that they're going to be able to focus different treatments for that very specific kind of pain. And they're working on that now, working on ways to block substance P more effectively. And there are already several studies in the works on that. So that's the last thing I want to point out to you in the way of update on those problems. With that in mind, I don't know if there's anything more that you want me to cover, specific questions. If so, please submit them, but I'll leave it there, I guess. The other thing is, at the end of this, we'd like to hear your feedback. If you have time to fill out a quick survey, we would appreciate it. Things that I could do better, things that you want to hear about from these lectures, ways that we can improve our outreach, and share more information with you. You'll also get an email within 24 hours that has this webinar in a recorded format, for better or worse. So look for that. And then the next Valley View University is going to be, let's see, tomorrow at 12 p.m. And that's going to be urology, Dr. Castle, who's going to be talking about robotics in urologic surgery. And with that, thank you very much. Yeah.
So what are
Okay. All right. Go ahead with the questions.
ways to prevent Morton's neuroma?
So important ways to prevent Morton's neuroma, flexibility in your calf, like I probably beaten to death. Shoes that are wide. So don't wear shoes that compress side to side. That pinches the nerve and creates injury to the nerve and makes it larger and more irritated. So wide shoes. We talk about hills and heels. So anything that isolates pressure on the ball of your foot, like going up and down hills, and obviously around here, you got to do it. So you still have to take those hills. But heels, high heels, also really concentrate pressure on the ball of the foot. There are some shoes that have a little bit of a roll to the sole, kind of the classic Hoka style shoe, or a lot of shoes that incorporate that now. So those kind of shoes can also be effective in preventing Morton's neuroma. You just have to make sure the shoe is wide enough and make sure that you have adequate flexibility in your calf.
Could you address foot arthritis issues?
Um, It's a big topic. Is there a more specific question on that? I will say foot arthritis is particularly challenging because most of the time when we talk about arthritis, we're talking about osteoarthritis, which is wear and tear arthritis, for which we really don't have a cure. In the foot proper, in the knee and the hip, you can replace the joint. In the foot proper, really what you're talking about there is fusing the joints. And that takes away a little bit of mobility. It can be very effective at relieving pain. Fusion of the great toe, when people have that painful area around the bunion, that's one of the highest success and patient satisfaction surgeries that we do anywhere. It really takes away the pain, keeps you at full function. When you start talking about fusion of the joints near the ankle or in the middle of the foot, yeah, those are a little bit longer recovery and a little bit more limiting in their long term. So arthritis in the foot should really be dealt with good support. Keep yourself strong, keep yourself flexible. You can use things like topical Voltaren. That's that anti-inflammatory topical. There are lidoderm patches or Salon paws, they're called, that have lidocaine in them. So different ways to kind of keep the pain at bay. But it is a uniquely challenging problem because we don't really have good solutions for it.
So specifically MTP joints.
Yeah. So the big toe is, like I said, the big toe lends itself to either replacement or fusion. The fusion of the big toe joint is very effective, and it does result in a fully functional and pain-free foot almost every time. Of course, there are risks to any surgery, but that is a very effective surgery. The other metatarsophalangeal joints, a little bit more challenging. You can replace those joints. That lasts a certain length of time and does take away a little of the strength from them. So.
For exercise, do you recommend Hoka style shoe or the minimalist type shoe?
So I'm not, I think there's a reason that the minimalist shoe fad passed. I know that in the early 2000s, when Born to Run came out, everybody was into minimalist shoes and five-finger shoes and so forth. I think that there were a lot of injuries in those shoes and a lot of people who are just uncomfortable. They're not wrong for everybody. Some people can get used to that. Their feet can be strong enough that they can be very effectively supported in a minimalist shoe. And then all you're trying to do is prevent them from getting a puncture wound. So Hoka is when the pendulum swung all the way to the other side and they said, well, we're going to go maximalist. We're going to make this sole as big and thick and cushy as possible. Some Hokas are great. Some Hokas, in my mind, have a little bit too much play. They have a little bit too much medial lateral instability. They're just a big, squishy, soft shoe. And I think that is not ideal for many people's feet. To me, if you can get a Hoka style, that's great. But if you have some stability, some medial lateral stability, I think that's a better choice.
Do you like the cushion in Hoka? What about the heel drop?
Heel drop, I find that heel drop is kind of an individual thing. I think even among top runners, you're going to find that there's an individual variation on that. I'm not adverse to having a negative or zero drop heel. But again, if you have tight calves, you're going to have more problems because that shoe is not going to, you're not going to get any ground reactive force under your heel. All the pressure is going to be isolated to the ball of your foot. Some people who are toe runners or forefoot runners are very effective. They don't have a lot of injuries. But others of us, if we tried to get into a negative heel or a shoe with the heel lower than the ball of the foot, um, a lot of us would get injured because we just don't have the natural flexibility and we haven't used that type of shoe for long enough. So I think if you're going to do that, you do it gradually, you do it carefully, and there's just individual variation on that. I don't have a strong opinion one way or the other.
So, are you saying that surgery on a bunion can leave the joint at the base of the great toe flexible?
So surgery on a bunion doesn't have to involve the joint at the base of the great toe, what we call the bunion joint. The bunion joint often has a large prominence of bone that has to be shaved away. To get to that bone, you have to enter the capsule, which is the lining around the joint. And so anytime you enter the lining around that joint, you are going to be causing some stiffness that has to be worked through physical therapy. But there are some types of bunions where all you're trying to do is straighten the alignment of the bone from farther back in the foot. And those kind of things, you don't have to enter that joint. You don't have to have extra stiffness. So there are ways to avoid that joint. I will be honest with you, most bunions, they do have a bone prominence that people want removed. That's just for shoe fit, for cosmetic reasons, and so forth. And when you do that, there is some stiffness afterward that has to be worked through. Anything else? Okay. All right. Well, thank you all.